Welcome to this special edition of The Points of Care, the official podcast of the journal Diabetes, Obesity, and Cardiometabolic Care. This is the American Diabetes Association's new journal for clinicians, educators, and advanced practice professionals. I'm Dr. Richard Beaser, your podcast co-host. This podcast is coming to you from the American Diabetes Association's 2026 Scientific Sessions in New Orleans, Louisiana. It's based on content from the Diabetes, Obesity, and Cardiometabolic Care Journal Symposium entitled The Cost of Obesity and Its Treatments that was just held prior to this recording session. It gives me great pleasure to welcome the faculty of that symposium here with me today, who will be introduced in greater detail in a few moments. Dr. Lou Aroney, Timothy Dahl, Melanie Jay, and Catherine Ferguson. We're all well aware of the epidemic of obesity. The new journal, Diabetes, Obesity, and Cardiometabolic Care, reflects a recognition by the ADA of its importance among the key issues facing us today. And who today is unaware of the issues of cost? Everywhere you turn, there are discussions about cost, its implications that permeate all aspects of our lives. That's why for this inaugural journal symposium, the editor-in-chief, Alyssa Siegel, and her editorial staff chose the issue of the cost of obesity and its treatments to highlight. It's of major importance, and I know that our speakers have considerable insight into this important topic. So I want to turn things over to my co-host, Dr. Lou Aroney, who will be moderator of this panel discussion and also was moderator of the ADA Symposium. Lou is the Sanford I. Weill Professor of Metabolic Research at Weill Cornell Medicine in New York, a former president of the Obesity Society and founder and chair emeritus of the American Board of Obesity Medicine. He is Pharmacologic Treatment Subcommittee co-lead for the ADA Professional Practice Committee. Lou?
Thank you very much, Richard. It's really a pleasure and an honor to be here at this inaugural session. We have three distinguished speakers with us today who will be addressing the issue of the cost of treating obesity and implementation issues. And each one will present for 6 minutes, and then we'll have a discussion. So our first speaker is Tim Dahl. Tim is the Executive Director of Health Economics of Global Data, where he leads a team providing economic research and insights to federal and government agencies, life science companies, and nonprofit organizations. He brings more than 30 years of experience studying the economic burden of chronic disease and the value of disease prevention and treatment, with particular expertise in obesity and its complications. Tim holds a master's degree in economics from the University of Wisconsin-Madison and a bachelor's degree in economics from Utah State University. Tim?
Great, thank you. So today we spoke on 4 manuscripts that have just recently been published in the journal. One is on estimating the health, economic, and social benefits of obesity treatment using microsimulation modeling, and then 3 applications of the model. One on the cost of inaction in treating obesity in the U.S., one on the benefits and costs of treating obesity among adults in the Medicaid program, and then another for the commercially insured adults. And each of these journal articles was designed to inform treatment policy for different subsets of the population: the Medicaid population, the commercially insured population, and even the Medicare population. The focus of our work was on people who currently don't have a clinical pathway to treatment. So we specifically focused on people with obesity that have no prior history of diabetes or heart disease to show what the clinical and economic value of treatment would be. And so we simulated for each person as they lost weight, what would be the implications on biomarkers, their not just their weight, but their blood pressure, their lipid levels, their hemoglobin A1C level, and then how this would translate into reduced incidence of disease, the complications of obesity, and then how this would affect healthcare costs and how their improved health would affect labor force participation, missed work days from work or absenteeism, productivity, quality of life, and mortality. What we found was that, first of all, when you look at the BMI distribution of people, quite a few people, about a third of people with obesity would benefit from, say, lifestyle intervention or some of these older FDA-approved medications where they just need maybe 5 or 6% weight loss to exit obesity. Whereas 2/3 of the people with obesity need something more substantial, such as modern obesity medications like semaglutide or tirzepatide or surgery. And so we modeled the clinical aspects, the economic implications, the mortality implications. What we found was that there's a fairly large return on investment to treatment. When you look at, for example, the Medicaid population over a 5-year period modeled, the return on investment was $3.81 in social benefits per dollar invested in treatment. It was a little bit smaller for the commercially insured population, but $3.09 in benefits per dollar invested in treatment. The challenge, though, is that many of the benefits accrue to people like the households in terms of improved quality of life and reduced mortality, and they don't show up on a budget line for the employer or the healthcare system. And so one of the key takeaways from our study is that if you make investment decisions in obesity treatment based solely on budget items in terms of how much money can we save, then you're going to underinvest in obesity treatment because many of the benefits don't show up on that balance sheet. Another key finding of our study was just helping to reframe the issue. When we think about treatment for obesity, many people will say, well, okay, this is what the cost would be if we provided treatment. If we don't provide treatment, the cost is zero. But the cost is not zero. There's a cost to not treating, and that's what our study looks at. That cost is higher incidence of disease and mortality, reduced health, higher medical expenditures, reduced labor force participation. So what we tried to do is reframe the question from what's the cost of treating versus nothing to what's the cost of inaction, and it's quite high. So that's just kind of a summary of our findings, and we tried to be conservative in our assumptions, recognizing that this is a controversial topic, that many people want to do the right thing and cover obesity treatments, and they look at the budget and say, we can't afford it. And I think that's the major finding of our study is you can't afford not to do it.
Thank you very much. That's terrific, and I'm looking forward to discussing it in a few minutes after our other speakers. Our next speaker is Dr. Melanie Jay. Dr. Jay is a professor of medicine and population health at the New York University Grossman School of Medicine. She's a general internist and board-certified obesity medicine specialist who sees patients at the New York Harbor VA in Manhattan. She serves as director of the NYU Langone Comprehensive Program on Obesity Research and director of research collaboration and mentorship for the Division of General Internal Medicine at the Grossman School of Medicine. Her research focuses on improving the treatment and prevention of obesity, particularly in primary care settings and in vulnerable patient populations. Dr. Jay.
Thank you so much for having me. So I am a general internist, and I do mostly obesity medicine for my clinical practice and obesity research and leadership. And my role in this conversation is not to talk about dollars and cents because I'm not a health economist, but to put the value of obesity care and some of the hidden costs and benefits to make sure that we keep those in mind when we're discussing costs. So I talked about how we are in this moment where for the first time we have highly effective obesity treatments that are accessible to a lot of patients, although not everybody, and that we have this opportunity to really improve obesity care. And that we know that when we treat obesity, for my patients, that even modest weight loss, which we can get from intensive lifestyle, can start to prevent diabetes, but when you can get up to 15% or more weight loss, for patients who are high risk, you can start to improve mortality. And what Tim Dahl had talked about as potentially saving 5.3 million lives by implementing obesity treatment more widely really struck with me with this conversation. But there are a lot of challenges to doing clinical care, even in a place where I work, where we have a lot of team-based care and resources. So when we talk about what is good obesity care, it really involves shared decision-making with the patient. So helping the patient understand the treatments and understand where their patient is and their values and their risks, and then coming to a decision of what treatment to make. And that really takes some time and some thought. And then even once, for instance, I talked about a case where we had decided with the patient to go on tirzepatide, but then I talked about all the different issues and potential problems that arise that we have to address. So the first one we talked about was access. A lot of these medications are very expensive, and even when the insurance covers it, a lot of clinicians have to do prior authorization. At the VA, we have to get it approved because they're non-formulary, and there are some loopholes and some challenges to even getting the medication, so that takes time. And then there's a lot of disparities in who gets access. So the patients who are most vulnerable, who have the most comorbidities, are patients who are least likely to get it, and some of the treatments and medications are less likely to be prescribed in patients who are African American and Asian and rural or socially vulnerable. So that's the first issue. And then once we even get the access to the medication, then we have to make sure the patient's taking it safely and taking the right dose. So there is a titration that has to happen, and in clinical trials, this happens kind of formulaic, but in clinical practice, we really take into consideration the needs of the patient, and that we're getting at a dose where they're going to have the fewest side effects and have the most benefit. And then, of course, we have to address side effects. We have to alert the patient to what side effects we might expect. Up to 80% of people have some sort of GI side effect that we have to take care of. And then there's some really serious side effects that we have to warn patients about so they know to go to the hospital, for instance, if they're having severe abdominal pain and a fever. And then we have to address lifestyle because we want to make sure that that people are still eating healthfully, that they're still addressing their lifestyle, and there are recommendations and guidelines that have come out to do this, but it does take resources and time. And all these things are things that affect adherence to medications. And we know that adherence to these medications is very low, and in some studies, only about 25 to 35% of people are still taking the medications at 1 year, although we also know that a lot of people who stop the medications will also reinitiate them. And so these are the kinds of things that we have to be in contact with our patients about. And then the last really big issue that we deal with in clinical practice is obesity stigma. And there's obesity stigma in terms of getting treatment itself. A lot of my patients feel like they have to lose weight the natural way, and that provides a conversation about how obesity is a chronic disease and how there are a lot of barriers to weight loss with metabolic adaptations and hunger hormones once someone loses weight. And then also there's stigma even when someone's on the medication that they're judged for taking the medication, and that can affect adherence as well. And so for all these issues and the hidden costs of treating obesity, and then all the benefits that we're going to get, we really need to take this opportunity to improve our healthcare system so that there's more team-based care, there's more safety monitoring, there are more resources because we have a physician shortage. There's never going to be enough specialists to do this work, and it's going to take primary care doctors as well as better systems and team-based care to improve care. And so as we are thinking about the value of care and how important obesity care is for saving lives and decreasing other costs, we also have the opportunity to make our health system better.
Thank you very much, Dr. J. That was great. Now we're going to go to Catherine Ferguson. Catherine is the Vice President of Federal Advocacy for the American Diabetes Association, where she works to advance policy solutions to improve prevention, care, and treatment for diabetes and obesity. Catherine brings over 25 years of expertise in driving healthcare and public health policy and advocacy change across state and federal programs. Prior to joining the ADA, Catherine led governance for a rural health care system in southwest Montana, and previously she served on the staff of the U.S. Senate Finance Committee and was involved in the passage of key congressional legislation, including the Affordable Care Act. Catherine has a Master of International Law from the University of London in England. Catherine?
Thank you so much. So when we talk about the cost of coverage, it's really important to understand that coverage in the United States is fragmented. We do not have a uniform system. We have lots of different public and private, government-funded and employer-sponsored payers in this country, and every single payer has its own structure, benefits, coverage decisions, and so when we're trying to address obesity care and the coverage gap, we have to actually go to each one of those payers. I'll focus on a couple of the largest segments of the payer population. So we have the Medicare program, which is a very large program. It's about 20% of the population, and it primarily provides health insurance coverage for individuals over the age of 65 and individuals with disabilities. And it is, until very recently, coverage of obesity medications has been prohibited. And so there's been a lot of efforts to educate our federal program centers for Medicare and Medicaid about the benefits of why obesity is a chronic disease and why there should be efforts to look at ways to improve the health of older Americans with obesity. As a result of a lot of that work and collective effort, the administration announced that they will be initiating a temporary program that starts July 1st of 2026 and goes until the end of 2027 for individuals that qualify in the Medicare program to provide access to obesity medications for $50 out of pocket. The administration will be working to set up a broader, longer-term demonstration pilot program to look at coverage over a longer period of time. But this is the initial investment to get some data and to work with health professionals to provide access in the short term. Similarly, we have the Medicaid program, which provides access to healthcare coverage for individuals who meet certain income thresholds. So it's for low-income Americans across the U.S. There are 50 different programs. It's jointly funded between the states and the federal government, and every Medicaid program has its own coverage criteria. There is some dynamics within the Medicaid program in terms of people going on and off the program. People tend to have higher health impacts and needs and chronic conditions. Obviously, there's socioeconomic demographic issues. And so looking at investing in coverage and treatment for our most vulnerable is a really important priority for the ADA and many other folks who are working on this issue. Similarly, at the state level, we have the state employee health plan programs, and those cover state employees and some local programs, as well as sometimes policymakers. Those programs are unique because state employees tend to stay with their employer, tend to work for the state for a long period of time. And so making investments in coverage and access, you can actually see the health improve over a period of time, which is really important. There are some considerations in terms of cost, increase in potential premiums, other dynamics that can be headwinds in the conversation. But in terms of the data that we have and the investments that Tim talked about, there's some opportunity there to really demonstrate value over the short, medium, and long term. And finally, we have the biggest group of folks who receive coverage through state employer sponsored insurance, and that's about 66% of the population. There's a lot of variety in terms of coverage, in terms of employer size, industry, wage, how the loyalty of those employees over time. We see, based on Kaiser Family Foundation's reports and surveys of the employer-sponsored coverage, that there is a growing interest in coverage, and we see most of that with a large employer population with employees over 5,000. And basically continuing to have those conversations around what is the value, utilizing the effort and the model that we've been working on with Tim Dahl to demonstrate the value and demonstrate the impact of not making those investments with each one of those payers.
Thank you all. You've given us an awful lot to think about. And back at the symposium that we just had, there was also a nice discussion and some questions and answers that brought out some interesting points. So Lou, perhaps you can work with the faculty and give us a sense as to what was discussed.
Sure. It was really an amazing discussion which emphasized some important points. One, which you brought up, Tim, was the cost of inaction, the idea that there are 5.5 million preventable deaths, 5 million diabetes cases which wouldn't occur if we were treating obesity, and 5.5 million heart failure cases, and many, many other millions of preventable cases. The economic cost of 10 to 13 trillion dollars in foregone benefits, including 1.8 trillion in avoidable medical expenditures. I mean, these are unbelievable, unimaginable benefits that we are not achieving because of the bias and stigma about treatment of obesity and perhaps the sticker shock of the cost of treating. Dr. J, you told us about some of the difficulties dealing with treatment and the complexities of the system that you are dealing with on a regular basis, the potential benefits, ways of delivering care which could improve the outcomes. And Catherine Ferguson, we heard about federal and other approaches. The most exciting is the Bridge program, and it appears that there is some hope for the future. We're very excited about that. So the question, where do we go from here? Are we going to be able to progress? And I, for one, having been interested in this topic for 35, 40 years, believe we've finally gotten to the point where the weight of the evidence, if you will, is building to the point where treating obesity makes perfect sense. We published 2 years ago that you could reduce the risk of developing diabetes by 94% in people who are treated with one of the new medications. 94%. Think about that. The vast majority of diabetes may never occur, I mean, what's the value of that? So how can we get this done? What do we need to get it over the top so that people can have this and have better lives?
Well, I think we need all of us working together to advocate for the change, for the value, to change the concept that people can not cover, right? If we have everyone investing and if there's a stigma there about not covering, that's where we need to get to, so that it's a disease. People deserve access to treatment. The kind of data that we're working on with Tim, I think, helps to tell that story, as well as many of you in your investments, and making the case, just continuing to make the case. As we have more data and evidence, we'll see more and more the health benefits and how they're materializing in the system. I think the data that will come out of the Medicare Bridge program is going to be hopefully very helpful to us in continuing to make the case to other payers in the system.
Yeah, and we have to get the patients involved in that advocacy, because there's so many more of them than there are of us, and there's so many opportunities with social media to counteract some of the misinformation out there and to really make the case of why we want to improve people's health and why these things should not be denied to people who really need them.
Well, the treatments don't do anything if people aren't using them. And I think the biggest access issue right now is just cost. And fortunately, there's new innovations coming out. There'll be continued pressures to bring the price down, and that will help improve access. I think 10 years from now, we won't even really be having this type of discussion, because hopefully by then everyone that clinically would benefit from access will have it. But the question is, how do we get there over the next 10 years while the economics are becoming more favorable?
That's right. And you pointed out that when you look at blood pressure medicines, for example, or lipid-lowering medicines, as the prices come down, things that were in demand, but the price was too high. We weren't using them for the treatment of blood pressure, for example. Now they're commonly used in first-line treatments. Do you anticipate that?
I do, because I think many of these discussions we were having about statins and antihypertensive medications a couple decades back. I think the exciting thing about obesity treatment is it can fundamentally change the healthcare system. The demand for different types of doctors and nurses and it just so many people can benefit. It's exciting what's going to happen in the future.
Yes, and I would agree with that. It's just this increased demand for treatment is an opportunity for us to expand how we deliver healthcare so that we can benefit more people. It will be interesting because I anticipate that as the medications come down in price, then we're going to have some of the same challenges that we have with high blood pressure medicines and statins, which is adherence is still going to be an issue, right? It won't be the costs now that keep the adherence going. It'll be people not wanting to be on a medication their whole lives, or really having them understand the value. And so we should anticipate some of the benefits that will happen and then some of the challenges that will happen down the road. And we can use some of these older medications that have come down in price as kind of our roadmap to what might have to happen to improve care.
Very interesting and a lot of important points brought out. And I think as we go forward in time, there'll be a lot more efficiencies and it will be a lot more effective to treat people with this condition. Lou, what are the key take-home points that you would see from this conversation?
Well, I think that the benefit of treating obesity is becoming very, very clear. Now we're seeing that the cost benefit is clear, that we can not only give people health benefit, but we could actually save money, or we can have cost neutrality. And that is a very, very important point when we look at the price of the medicines. I think another key point is that not everybody needs the same kind of treatment. So it may be that people who are at the higher end of the severity spectrum need the new second generation GLP-1s. Maybe we can use the less costly drugs in some of the lower risk patients who are younger and have fewer comorbidities, but they can still be treated. But all in all, I think that we have a very positive message here that the system, thanks to a number of innovations, both in the development of drugs and also financially, like the Bridge program, these things are going to bring obesity treatment to a very large number of people around the country, and that's going to change healthcare. And this is something I've been thinking about for a long time. If you can treat obesity, you won't have as many people with all the complications. And think about the value of that. There is so much value. You treat the diabetes, and you also get the hypertension, the hyperlipidemia, the sleep apnea, the osteoarthritis. I mean, that's going to be the value of treating obesity, and we're beginning to see that now.
Thank you all. So as we conclude, I'd like to remind our listeners about another special podcast featuring ADA podcast host, the podcast of the hosts, that will review the highlights of this year's ADA scientific sessions. Also, I'd like to encourage our listeners to see this current edition, June 2026, of Diabetes, Obesity, and Cardiometabolic Care. The accompanying papers from both this symposium and this podcast will be freely accessible on the Diabetes, Obesity, and Cardiometabolic Care website. Diabetes Journals, diabetesjournals.org/DOCM-CARE, with a link in the episode notes. Also, the URLs for directly accessing the collection and the individual papers will be listed in the episode notes. Watch for our next journal issue and the next episode of this podcast, both of which will drop in mid-August 2026. And do subscribe to the Points of Care on your favorite podcast app so you won't miss what's next in diabetes, obesity, and cardiometabolic care. The Points of Care is made possible by our dedicated donors, listeners, and partners. Thanks to your support, we're changing the future of diabetes. I'm Dr. Richard Beaser. On behalf of today's co-host, Dr. Lou Aroney, and our faculty, thank you for joining us.